We're at the IAS meeting here in Vancouver, BC. We're here with Susana Valente, and you're with the Scripps Institute and the Florida end of it. And we appreciate you coming to talk to us today about something that seems very novel, at least to me anyway. But the presentation, the symposium that you were in had various versions of ways to approach the virus, killing or doing whatever it's going to do to the virus from a cure perspective. And yours was putting the virus to sleep. Tell us about that.
Yes, so basically by taking advantage of a specific property of the virus, which is this ability to amplify its viral production using a specific protein called TAT, and having inhibitors to this protein, we are able to lock the virus into this very repressed state. So basically our idea is that instead of shocking the reservoir to allow its killing, we were basically suppressing it to a point where there's no events of viral rebound from latency, and thus we will reduce any events of replenishment of the viral reservoir, and though over time this reservoir would shrink in size. So this is a unique property of the virus. We're targeting a viral protein, so in terms of toxicity, there is a lot less issues of interacting with any other cellular protein. And basically, we're taking advantage really of that. And somehow, by blocking a subset of these activities of that, we are putting this virus into a very, very, very repressed state. And we have shown that even if you treat the cells prior with this compound in presence of IRVs, and then if you remove all the drugs, for the period of 21 days that we've tested so far, we have no viral rebound. And interestingly, it seems from preliminary data that also integrated viral DNA is going. So basically there's less infected cells over time, and this is probably because we're not replenishing the system, because there's no virus production as well in the affected cell. In opposite to IRVs, that the virus is still there and has the ability to rebound. In this case, we were really locking it into a very repressed state. There's no hypothesis of coming out and infecting the neighboring cell.
So how would you keep this induced? Would it be through oral administration of pills?
So this is still far away from
Right.
being in the clinic. We're still in
I mean, I'm just forward thinking.
yeah,
or something.
forward thinking. We don't really know exactly all the molecular mechanisms that are behind it, but so far we would think that this could be added to antiretroviral therapy as another drug. Because of the way we see that there's no immediate viral rebound, this could also allow for IRV interruption to give a break to the patient.
Which is something we kind of forgot about all of a sudden.
Yeah.
But now maybe this makes it more realistic.
If we suppress the virus to a certain point and then we remove all drugs, there's no rebound. This will allow the person to take a holiday, take a vacation, feel better, and then come back maybe to it if the virus is rebounding, or maybe they can keep on a single drug alone, this suppressor.
Oh, okay.
Those are things that potentially is something that will be to explore in the future. Yeah.
So what are your next steps?
Next steps, we're really trying. So there's the molecular aspect of it. We need to understand exactly what is happening at the HIV promoter that enables it to rebound, and we're trying to study those from a very molecular perspective. Also, we're going to be doing studies in humanized mice. So we're trying to understand if in humanized mice we can see a reduction in the size of the reservoir over time, and potentially in the next year we'll be testing this in non-human primates with SIV and see if we can reproduce those same studies in SIV.
So is this so far a single compound, or is there a whole host of compounds that you could evolve? Or?
So far we're working with a single compound. There has been analogs that have been generated. But so far we're still working with this same compound.
So, is there anything that you want to contribute to that? I mean, I know you're very early in the research because you're getting into humanized mice.
I think there's something also that comes from inhibiting. TAT is a protein that has pleiotropic activities in the cell. It's also very involved in neurotoxicity. So 50% of patients with HIV experience some form
Neurological
of
issues, yeah.
neurological issues, and TAT is responsible for part of those neurological issues. So this is something we have also been explored, and we have seen in preliminary data that we can reverse some of those toxic effects caused by TAT.
Does this cross the blood-brain barrier then?
Yes,
Yeah,
it does.
okay.
Yes, it does.
That was maybe an assumption I should make.
Yes, it does.
But it also seems that this would be, we talked earlier about inflammation, it would be
Yes, it's
reduction.
something exactly. So this, this low-level ongoing replication that we see in latent infected cells is also believed to be part of the chronic immune inflammation that we see, and those are things we were looking at in cells from patients, treating them with this compound and seeing if we can reverse that inflammation that occurs with this low-level expression of the virus. Those are things we're currently studying.
This is all very exciting. I'm hopeful that you'll get back with me and we can review this again as it moves forward. And we always have these wrinkles that show up on the way, but
yes,
not always, but occasionally. And
many times.
we hope that there are few in your future.
Thank you.
Thank you very much, Susana, for being here.